So we see a lot of fractures. We see adult fractures. We also see a few pediatric fractures. Now, how are pediatric fractures different? Let's see if I can bring it out. So first thing is we will be talking about certain products, but please, I do not have any financial interest in any of them or in the surgeries that we're going to be talking about. First thing is, how is pediatric orbital anatomy different from adults? Now, if you look at these two cross sections, you would see that the face actually looks quite different. Okay, so this is an adult face, this is a pediatric face, and children have a large cranial cavity, a large skull, but a very small face when they are born. And around 5 years, the face starts to develop further until you attain this adult situation where you have this ratio. Okay, the upper part of your face, the mid face, and the lower face having somewhat similar ratios. Why is this so? So the sinuses develop differently. You start with the maxillary sinus, they're hardly present at birth. They develop a little up to the age of 3 years and then they stop developing. But after 7 years, they start developing again. And the unerupted teeth from the, especially the molars in the upper jaw, are actually occupying that space. That is one. The second is because the cranium is much larger, these children actually present with cranial fractures or roof fractures in the first 5 years of their lives. Okay, 5 to 7 years. And then once the maxilla starts developing at 7 is when the forces are redirected and you get more of fractures of the floor of the orbit. Okay, so you have different kinds of fractures. You can have fractures which blow out because of raised orbital pressure. Okay, because children have a more prominent frontal process, they get more injuries in this area. But once your cheeks develop is when you would have fractures involving the midface. You could have fractures with combined with fractures of the cranial bones or with other facial bones as well. Now, when you talk about the roof fracture, you sometimes get a fracture which is coming in. So it's a blow-in fracture. You can have herniation of meninges, you can have herniation of brain tissue into the orbit as well. Okay, orbital fractures typically blow out, but this is what you would generally see in an adult. Okay, a large fracture, you can see the fat herniating in and dragging the inferior rectus down. Okay, what we generally see in an orbital fracture, you see swelling, you see ecchymosis, you get motility disorders, you can have diplopia, and of course you can have globe as well as optic nerve injuries, and these are also important for us to detect. And on the systemic side, you could have head injuries which would take precedence. You could have injuries of the orbit and of the thorax and the abdomen, which again would take precedence over managing an orbital fracture. Now this picture typically shows what happens in an adult. Okay, what is different? Again, we talked about the anatomical aspects. The other is the children have soft elastic bones, okay, unlike the brittle bones that adults have. So here what happens is you get the initial impact, you get a crack, a linear fracture, some orbital content may go into the maxillary sinus and then get entrapped there. So it closes. Okay, it snaps back. And the problem here is, unlike in the adult where we showed a larger fracture, you have the risk of ischemic necrosis to the structures entrapped, especially if it is the inferior rectus muscle. Okay, this is what a typical pediatric fracture would look like. Okay, they usually do not have the kind of hemorrhages or the ecchymosis that you see in an adult. They usually do not have crepitation because air escaping into the orbit. These are things you don't see in a child. You would see a child with a white eye. The main problem is the motility restriction. They usually complain of pain, but the other big symptom is because of the ocular cardiac reflex. So they would have nausea, they would have vomiting, they would have bradycardia, and often they are misdiagnosed to have either these problems because of a head injury or because of an acute abdomen. So sometimes they are wrongly diagnosed and treated in that line before they actually end up with an ophthalmologist. What our other colleagues often miss is the eye movement problems, because children are not very cooperative. That's their nature, right? So this is what would happen in a pediatric fracture, a smaller fracture with a prolapse. This is one boy, we call him Karate Kid. So he was very good in his class. And he sustained an injury during one of these mock fights, and See, this is what happens. Look at his right eye, look at his left eye. There is just no movement. And you can see a part of his inferior rectus muscle prolapse, and it is pinched in by the floor, which has come back up, right? You would also find that there would be some restriction in down gaze as well. And this child was again presented 2 weeks later, where this is actually a medical emergency. This is a surgical emergency. You would like to operate on these children in the first 24 to 48 hours. You do not want that that ischemic necrosis to happen to the inferior rectus muscle. So that's another patient here. This is that boy's scan. This is what happens in a typical adult. Okay. So what do you look for? You look for the motility restriction. You get CT scans done, and you do a positive force duction test. Now this is difficult in children. In an older cooperative child, you can do a positive, a force duction test. But in a smaller child, you can do this under EUA, under general anesthesia. Okay, take them as soon as possible. Check for the force duction test, because some of these children might have a fracture without any entrapment, and those are the children who do not need any surgery at all. Okay. So these are things to watch out. Number one is the oculocardiac reflex. Is there a hemorrhage behind the eye? Okay. Are we dealing with an open globe injury? Because that would need treatment first. You would actually avoid doing a fracture surgery in such a situation, because you could actually rupture the globe or cause further injury in a situation like that because of the manipulation involved in orbital surgery. CSF leak. Okay. And of course, muscle strangulation. Now, how do we manage fractures? First thing is you expose the floor. So you do a swinging eyelid incision, go into the floor. The important thing is to release the entrapped tissue, and there's the muscle or the fat or both. And then you have to cover that floor. So in a child, you actually need to increase the size of the fracture. So you have a thin hairline fracture, you have to increase the size of the fracture. We use bone purchase for that, so that you can release the trapped contents, bring it back into the orbit, and then you have to cover it. You do not reduce fractures in this situation, right? You just cover it with an implant. Repeat the force duction test to ensure that you've released the tissues, and then you close the incision. We will skip this. So basically, there are different kinds of implants. Craniomaxillofacial surgeons will generally use autologous bone. We are more comfortable using material like this. So you can use a silicone sheet or porous polyethylene, or in larger fractures, you might use a titanium mesh. But in children, this titanium mesh is something that we would not recommend. Okay, you can have composite materials. Again, we'll skip this, but these are newer implants that have come. They are resorbable, and they are preferable in pediatric fractures. The last three here are available in India. This is fairly affordable, but the other two are these are preformed orbital plates, which are quite expensive. Even the screws that come with them are absorbable screws. Okay, so my last slide. So this is that same karate kid. You can see that after his surgery, he is able to look up, but then he still continues to have a little bit of diplopia. Remember, this patient presented 2 weeks after his trauma. Okay, so he still has a little bit of diplopia in up gaze, but what is very important to us is he does not have diplopia in primary gaze or in down gaze. Okay, most recently we've operated on a child 3 weeks after presentation. Again, this child was admitted with a head injury, apparent head injury, and that is where time was lost. And you see, what happens is when this muscle is pinched in, this ischemic necrosis would either cause weakness of the muscle or even cause fibrosis of the muscle. So they would continue to have some residual problems, either in up gaze or in down gaze, or both. So very important. Number one is beware of entrapment, because that is something that we all need to watch out for. Hopefully most ophthalmologists would pick it up. Often the emergency care people miss this sign, and which is why we as ophthalmologists need to keep talking to them about it. Whiteout blowout fractures is important, because since the surface looks pretty quiet, they're often missed out. And we just talked about orbital implants. They're silicone implants, porous polyethylene is easily available. And if these once these become affordable, yes, this would be the preferred material to use. That's all. Thank you. Any questions?
ANIRBAN, in which type of cases generally land up with a ischemia of that muscle? Which type of, from MRI or sorry, from CT scan, how
Mhm.
can we the understand that this muscle is vulnerable for ischemic changes?
First thing is that when we see fracture, we generally don't ask for MRIs. Okay, so it's a CT scan that we ask for, and in a CT scan, it's difficult to tell whether the muscle has already become ischemic. But if you see a trapdoor fracture, yes, that is the situation where you would generally be dealing with a situation where the muscle would potentially be injured or would be ischemic. Okay,
But
MRI is something that we really don't ask for in a fracture
yes, it
situation,
will be
anyways.
difficult for
Mhm.
radiologist also to tell by from the CT scan. Most of the time, this is we are facing. So it is the amount of ischemia, etc., is of course impossible except few. So next option is as per the book standard, if there is a no diplopia, no in ophthalmos, you should not touch.
No, you do
That's a
not need to.
medical legal point. So something happened in GA that now one child now very difficult for us to protect us. So in such scenario, to go for a early orbital surgery, reconstructive surgery, what will be your take home message to us or to the audience?
Okay, Jonathan, let me put it this way. Number one is, are we dealing with an entrapment? Okay, is something we have to be very clear about. So you see a movement abnormality, and let's take an example. Let's take a child who is about 6 years old. Hmm. You, the child has a motility disturbance. The scan shows that there is a fracture. The scan also shows that there is prolapsed content in the orbit. And what we expect at this age is that there would be a very small fracture. So one has to be very careful looking for the fracture because you can often miss the fracture as well. The next thing is you're checking the movements, which is important. What if there is no entrapment? So you need to confirm that. If it's a small child like 5 or 7 year old that we're talking about, there is no harm in taking the child for EUA because you would probably avoid an unnecessary surgery in a situation like that,
Yes,
right? And then everything has to be done with the consent of the parents. Of course, they have to be explained the situation that if this fracture is not treated, what are we going to end up with? I'm sure as sensible parents they would agree.
definitely. You want to say something?
Come on.
Just one comment. Another thing is
Yeah.
that, especially for the diplopia, it doesn't necessarily, especially these green stick fractures,
Hmm.
it doesn't necessarily have to be a muscle entrapment to have diplopia. Especially in older children, they actually come back with, you're not seeing anything on the CT scan, but they keep saying that they're seeing double, extraocular movement seems normal. Even you do a 9 gaze cardinal test, nothing, you can't even make out. But the child keeps on complaining.
Okay.
Then you go in, even you repeat the test or repeat the CT scan also, you can't see that fracture. Usually the intramuscular septae, if it gets entrapped between,
That will cause
diplopia
diplopia.
in itself.
Yep.
So I have at least 2 pediatric cases, little older children who are able to describe diplopia. So there it's just a small, on table you will see that there is a entrapment right there and just have to release it. In those cases, we don't even need to put a barrier implant also. You can just leave it alone.
Simple
So that one. And now with regarding the pediatric fractures, the bioresorbables, these implants are actually can shape it. It's a thermolabile thing, so you can shape it. You can use a template of the
Orbital
titanium
flow,
implant
Mhm.
and use it and heat it up in a water bath and shape it according to that thing, and you just put the bioresorbable implant in. So even you can do that even with osteopore as well as resolve. So
Mhm.
you don't really have to use a titanium implant even for a child.
And definitely screwing is in the pediatric is not a so easy task.
It's not easy
Sometimes,
and not recommended also because
yes.
it can cause a lot of late
No,
extrusion.
until
Yes.
the resorbable implants came, the
Yes,
option was
yes.
actually to remove the implants after 6 months.
Yes, yes. And I think that in near future the reservable implant will be the another option
Absolutely.
for us
Our
in
option,
orbital
and
research.
we have done after 2 years, 3 years. Actually, there is real bone formation,
Yes,
and you
yes.
can't even see the implant. It's just
Yeah.
real, as if there was no fracture at all after 2 years. Or so.
And even bone also grows very faster in younger age group. That's another option. If you can release, if it is no entrapment, you can just observe it.
So you don't even need to use a screw to fix it. You can just use cyanacrylate glue there and fix it. So that's enough for it to stay in place. And anyway, if you're using a bigger implant, you'll have to put it at the posterior edge. So you don't need to use a screw to eliminate having a screw at all. Even because the screw itself is the more expensive one than the implant. Because you can use it for 2 patients. The osteopore or even the big sheets, you can use it for 2 patients. But you can't. The screws are multiple, so each one of them costs, I think, around 5,000 screw. So it's not. So you can eliminate the screw quality itself.
Like most of these, there would be a lot of patients coming in the pediatric age group. Other than green streak fractures, many of them present late only, and they would have extensive injuries, extensive fractures, which possibly would not be fixed up with Medpor. So we have to go in, and bioabsorbable, they're very expensive. So there is something midway between. So we are using titanium. So you Recommend that, you just said, to avoid. So
After a year, we usually wait for a year before we remove it. Even though it says that 6 months, but 6 months sometimes it's not enough. Fibrosis occurs within that. So you might have, especially if there's multiple complex fractures in a pediatric age group, even though kids heal fast, sometimes they don't heal fast enough. So just so that you don't have to do a second, you wait for a year. Usually the ones with the complex are a little older children. Very young, very small children, very rarely we get very complex fractures. The bigger children, maybe more than 5 and more than 5 years or more than 10 years old, they usually these are the ones which will have complex fractures. Very small children, they may not survive the accident to actually have come, and if a complex fracture occurs in a very small child, they may not even survive the accident. So I've never had a child less than 5 years old, multiple injuries which we were able to see, because they don't land up in the hospital at all. They will not survive that kind of an injury. No, usually even after this thing, there is all the fat. This thing is also the fat cover also. After till up to 14 years of age, the malar development still goes on. So especially if you have any plates on the malar area, that you need to remove. The mesh is not that much of a problem. If it's just the mesh, we can just keep it. We don't even need to remove it. So the problem is where if you have plates on the this thing, plates on the malar region and on the brow. So these areas actually even they continue to grow even up till 20-25 years of age. They continue to grow the brow, the malar areas and all that. Not very fast, but they slowly they keep growing up till 20-25 years of age. So better to remove them in a younger child. If it's older, more than 18, I think we can just leave it.